Oh, that doesn't work so well. What I'm going to do, let's see, what I'm going to do is say, let's see, I'm going to take a minute. We're going to wait another minute or two before we start. I'm going to give you a few instructions, but hold on just a minute. We'll be starting in just a moment, everybody. Thanks, everybody, for coming. This is the Southwest Washington Provider Technical Assistance, How Are We Going to Get Paid Tomorrow webinar. We're going to be recording this webinar. I have a few instructions to give you if you have any, including if you have any questions or comments. But first, let me push the Start Recording button. Thanks, everybody, for joining us. Dale Jarvis here, calling from West Seattle. We're going to be talking about payment models that may be unfolding soon or in the not too distant future under the Early Adopter Program. Before we jump into the payment models, there's a couple things I want to cue you into. Everybody's on mute right now, and so I'm looking and seeing that there's a bunch of dashes through everybody's phone numbers because there's a bunch of background noise related to the webinar. If you have questions that you want to type in verbally, there's a chat screen that you can type it in where you can see type message here and press the send button. And that will pop up on my screen, and I'll be able to see it. And also, if you want to make your questions verbal, there's a little hand button on the attendee list, and if you click next to your name in that column, it will raise your hand, and I'll be able to see that, and I'll be able to unmute you, and we'll be able to handle things that way. So please feel free to raise your hand or type in the text. Sorry, my brain is having a hard time multitasking today, but that's okay. How we're going to get paid tomorrow is the topic of this session, and there is a short answer that I want to start with, which is through one of 4 payment models. And each of those payment models having what's called a pay for performance layer. A lot of the material in today's webinar is available to you through this thing called the Arizona Behavioral Health Payment Reform Toolkit, We're recording the webinar. We'll be getting slides out to you, and you can also see at the bottom of this slide there is a link to the website called azpaymentreform.weebly.com, and there's a whole ton of really great stuff that, even though it's been developed for the state of Arizona, it's very relevant to Washington, very relevant to Southwest Washington. So please feel free to go and check that website out and download the tons of stuff that's on there, or read all the different parts to dig more into this, because we only have an hour, a little less than an hour today. Today's topics are going to start with defining this term called value-based purchasing, talking about each of the big four accountable payment models, and talking about pay for performance. So it's very, very focused, very straightforward. The little diagram on the right side of the screen right now is a roadmap that we've developed for Arizona for how they can go about implementing payment reform in each of their systems in the state, which actually look a lot like the early adopter model in Washington State, how Arizona is reorganizing its Medicaid health plan system. So let's talk about value-based purchasing. One way to define it is through the following bullets. Payers hold the providers accountable for both the cost and the quality of care. So it moves beyond just paying for volume. Payers use strategies to reward providers for a handful of things that are going to make total sense to you, which include reducing inappropriate care, providing high-value care that's patient-centered, clinically effective, and cost-effective, that can result in bending the cost curve, i.e. saving money, and sometimes use strategies to put providers at risk if the above isn't accomplished. So the payment models and the pay-for-performance strategies really attempt to move the system away from paying for volume to this term called paying for value. I'm going to say a couple more words about the definition of high-value care. The first piece is there's been a bunch of research that's been done about what consumers think is high value, and it's really interesting because there's a lot of commonality among the research. It basically says, as consumers, we want accessible care provided by staff that communicate well. And if I were to add a few more phrases onto what the research is saying, we want to know that our provider is knowledgeable in what they're providing service about, and that they take the time, they spend the time with us to really listen to what we need, pay attention to whether we're absorbing the information that's being provided. So it's communication and access are really, really big pieces by people that know what they're talking about. Makes perfect sense to me. Clinically effective means achieves individual and system-wide outcomes. Or am I getting better? Can we measure whether I'm getting better? This is a really critical piece, second part of high-value care. And then the third piece is, does the care cost less than alternatives with comparable outcomes? So if two organizations were providing the same type of care, and one organization, and let's just say that they both got really good outcomes, and in one organization the average cost per case was $2,000, in the other case the other organization the average cost per case was $3,000. The organization that's getting the same outcomes for $2,000 instead of $3,000 would be providing higher value care. And as we start to measure outcomes, which Washington State is moving towards very aggressively, it's really important for all the providers to realize that we're moving from a situation where we haven't been able to do this cost-effective analysis before to an environment where we are going to be able to measure value because we're going to be measuring outcomes and we'll be able to measure the cost of cases. Now, there are two value-based purchasing elements. The first is called an accountable payment model, where the financial reward is embedded in the payment model, and I'm going to be talking about 4 payment models. One size does not fit all. And pay for performance. So you see that I'm doing a lot of repetition here. I keep using the term payment models and pay for performance. And the pay for performance is defined as where high-performing providers are directly rewarded for efforts to successfully provide patient-centered, clinically effective, and cost-effective care, and it comes in terms of a bonus. So there's the payment model, that's your core payment, and there's 4 different ones we're going to talk about, plus a bonus layer. So let's dig into those 4 payment models and see where we go. And if you have any questions along the way, don't forget to raise your hand or type in a chat message. There's a term called capacity-funded services, and this picture comes right out of the toolkit. And what we have with capacity-funded services is it's also known as the fire department model because its funds are generally paid in 1/12 monthly increments based on a budget that supports sufficient staffing and other resources to field the necessary staff to meet the potential demand. So what services are paid for typically in a modern payment environment with capacity-funded payments? Services where volume may fluctuate, but staff must be available to meet the need, such as crisis lines, ACT teams, community health teams, crisis triage and stabilization centers. There's a number of situations where if you pay in a different model, with the ebbs and flows of demand needing to have capacity, you may not be able to fund this. The project may go broke. So it's very important that if a particular service area really needs to be capacity funded, that we attempt to fund it that way. There's a handful of performance measures that are relevant for this type of service area paid with this type of funding. And I'm going to talk about the pay for performance components of this a little later, all at once. The second model, believe it or not, fee-for-service is still relevant where a payment is made for each service, because there are some situations where services can easily be billed in units, and the type of service doesn't fit into another payment model, such as emergency room services, urgent care clinics, respite services. And in a mature system, as it says here, the list is quite short. There's a little bit different set of pay-for-performance measures, and again, we're going to talk about them later. So far, you must be going, wow, this is pretty, this is like not very earth-shattering. Dale's talked about paying 1/12 and paying fee-for-service. Let me reiterate that for all the 4 payment models, there are services that make sense to pay via this model, and whatever model you're using, there should be a pay-for-performance bonus layer. The third model is case rates, or bundled payments, that cover the costs of a defined episode of care. I've talked with folks at various points in Southwest about case rates. King County has had mental health case rates for over 20 years. It's the longest running case rate system in the country. They're talking about bringing the substance use disorder system into the BHO via case rates. And it's basically in the form of a single lump sum or monthly installments. Services that are associated with discrete episodes, such as inpatient, detox, health home services, outpatient behavioral health care, Even some specialty services lend themselves to case rates. And again, there's a set of performance measures that we'll talk about in a few minutes. And the fourth and final model is subcapitation. And this is a per member per month payment to an accountable care organization or a comprehensive provider. And that payment represents the average expected cost of providing a package of services to anyone enrolled in the population who needs care. And what's different about this is we say basically, okay, so if you have, if you're the only provider in a given community, like if we went to a community like a bunch that I work with in Oregon where there's just one provider that's providing behavioral health services for the whole county, then we would want to think about paying subcapitation because the more that you move towards a risk-based arrangement with the providers, if you have good performance measures, the more that the provider can take responsibility for the cost and quality of services per a value-based definition. Now, what's also really important to note is that subcapitation doesn't work so well in a community where there are several providers providing care because what you have, because the question is how would you divide up the per member if there's 100,000 enrollees, you have to divide the money up based on the number of enrollees, not based on the number of clients. And so capitation generally doesn't work in a community where there are multiple providers and you're trying to assign lives, even though for mental health, even though people aren't using those services. So that was a little bit of a obtuse explanation. So if you want to ask for follow-up questions, which we're going to stop for a couple minutes and see if you have any, please feel free to ask additional questions about this. Now this next visual is called One Size Does Not Fit All. And what I did was I took 20 different services that you might find for a population of folks with behavioral health disorders, broken up into front door, crisis and acute care, and community-based services. And I played out a little example of saying it's really important to not move to alternative payment models or accountable payment models, those are two synonymous terms, before providers are ready to do that. So I've thought about phase 1, phase 2, and phase 3. So this might be year 1, year 2, and year 3. What we see is that front door services, in my example, I'm paying capacity funded, the fire department model, and I'm just paying them. That's how I'm going to pay them from now until forever. On the crisis and acute care service side, there's some things that I've decided I'm going to pay capacity funding. There's some things I'm going to pay fee for service. I'm going to continue paying fee for service in phase 1 and in phase 2. But what I might do is I might pay a case rate for urgent care clinics episodes, for inpatient episodes, for detox and respite care. I may consider a bundled payment, but I may, in this example, I felt like the provider system wasn't ready. We weren't ready to price out what the bundle amount ought to look like, and the provider system wasn't ready in my little example. And then you can see that there's several community-based services that are starting out with a combination of capacity, fee-for-service, and this thing called fee-for-service plus a bundle for person-centered health homes and behavioral health homes. So that's interesting. And this is the first time I've talked about a combination payment model where I'm paying fee-for-service for some of the services, and then what I'm going to do is I'm going to pay a care coordination case rate add-on for people that need care coordinations, because there are some services inside these health homes that you never can bill enough fee-for-service services because of the people that are providing the service or the type of service that are being provided. And so I may pay fee-for-service plus a case rate add-on to cover the full cost of these kinds of services. This is a very, very typical model that's being used throughout the country for medical homes and health homes, is fee-for-service plus a bundle. And in this case, I'm going to transition those to bundled payments, a case rate. And for ACT teams, I'm going to transition from capacity to bundled. For specialty behavioral health clinic, I may start with capacity funded. This is in Arizona. This is actually for Arizona. They're being capacity funded, and I might move them to subcapitation because in Arizona there's a bunch of places around the state where there's just one provider. But you have to look at each situation. So, that was a really quick run-through of 4 types of payment services, accountable payment models, and kind of how they get put together and phased in for care. What I'm going to do now is I'm going to give myself a new slide. I'm going to just put myself on mute for 60 seconds. I've got a little timer here. And I'm going to ask you to just think a minute about whether you have any questions or comments around the 4 types of accountable payment models. And then we'll spend some time digging into whatever questions and comments that you have. And you can do that by one of 2 ways. You can type in something into the chat, or you can raise your hand, and I'm just going to go away for a minute. Okay, got a couple questions. How would subcapitation work for substance use disorder services? So, what we would, so if there was a geographic region where there were 1 or 2 providers, we could divvy all the Medicaid enrollees up between the 1 or 2 providers, paying a PMPM to the provider, and anyone who showed up would get assessed and served, paid out of that money. If there were more than a few providers in a region, this divvying up, the math problem just goes south really quickly. It just doesn't work. So you'd have to have a small enough number of providers, and the providers would have to be willing to take on the risk of serving anybody who showed up based on their medical necessity. So there'd have to be enough capacity and enough money to make that work. Another question was, please explain why you might move ACT from capacity to bundled. So there are some systems where ACT, where people aren't getting. Well, there's a couple things that are happening. Some systems where not enough people are getting enrolled on the ACT team. So, for example, if the ACT team can serve 100 people and only 20 people got enrolled, but we know that there's a need for ACT services, we'd first try and figure out how come there's only 20 people enrolled, and what's going on here. And what some systems have done is they basically said, we can't afford, we're still not getting traction. We need to move to paying a bundled payment. But note that this is generally a capacity-based payment. And bundled is a second choice when something's going wrong. Basically, when not enough people are enrolled or getting enrolled. Now, that's not necessarily the best solution, but that's the situation where I've seen that play out. Will the payment models be dictated by the awarded MCOs, or will it be a collaborative process arriving at the most appropriate payment models with providers? So will the MCOs decide the payment models, or will it be more collaborative? Thanks. I'm just writing this down for later, for the people that aren't able to be here. So the answer is typically the MCOs decide. This often causes problems because there are different payment models being paid for the same thing. It's much better to have a single payment model game plan. The early adopter work group working with the health plans will basically hopefully have a conversation about this to decide whether we want, as part of their design work, whether they want to create a single payment model game plan. Should consider weighing in. But the health plans get to make the final call on this, because they're the ones that are at risk. And so and most payers generally are not willing to dictate to health plans how they should pay if they're putting the health plans at risk. How do community mental health agencies fit into these models? And then the rest of the question was, will the health agencies become specialty behavioral health care clinics or behavioral health homes? That's a great question. A community mental health center I, they they could get paid a bundled payment for health home services, fee for service or a case rate for specialty behavioral health care. I'm going to change this to care coordination / health home, and capacity payment for fire department like services. So, you know, community mental health centers do enough different kinds of service that I expect that these kinds of organizations are going to be paid paid in more than one way, in the same way that one size does not fit all screening shows, and it depends on what you provide. So if you're a community mental health center that provides a very focused type of service, you might end up having only one payment model. But I know that in other states, the health plans are really being encouraged / pressured / forced to move to value-based purchasing, which means these two categories, alternative and accountable payment models and pay for performance, that we're going to be discussing in just a few minutes. What payment models have the CCOs been using in Oregon? CCO payment models. They're using all four. Depending on the CCO and the service area. There's been a lot of discussion about how the CCOs can work together, and the most predominant thing that's been happening on the primary care side or the health home side is most of them have gone to fee-for-service plus bundled payment for the medical home or health home services, and then some of them are moving to a bundled payment, fully bundled payment for primary care. And so this is a big shift that's happening there. On the specialty behavioral health side, there's some, the largest CCO has moved to case rates for mental health services. This is in the Portland area, and they're still paying fee for service on the substance use disorder side. And other CCOs around the state are paying subcapitation for specialty behavioral health in the rural areas. So again, it's you have to think about, what is my community, who are the providers, so how many of them are there, and what's really important is you have to customize the payment models for your environment, and there is a logic to what this matrix ought to look like for a given community, and that's why it's really better to work together on a single payment reform strategy, as opposed to having each MCO do its own thing. How does benchmarking work in evaluating outcomes, specifically in the example of provider X and provider Y being compared for value versus cost? I'm going to put that question, a bookmark in that question, because we're going to dig right into that when we get to the pay for performance chapter that's coming right up. How do multiple MCOs fund a capacity payment model? Good question. The answer is by working together. It's the only way. They have to work together, and they have to basically coming up with a formula. And this is being done in other places for how they're going to jointly fund it. You can fund it based on number of enrollees at each MCO, or number of patients that are getting that type of service. There may be 2 or 3 MCOs that would have to work together to fund ACT or WISE. Is that right? And so that's right. That's right. So if you're going to not pay, if you're going to pay fee for service, then it's not an issue. If you're going to pay a case rate, it's not an issue. But if you're going to pay capacity payment or subcapitation, then what you need to do is this process of working together to come up with a formula. It's actually not rocket science, but it just means that there needs to be a certain level of collaboration, a high level of collaboration among the among the health plans. With subcapitation, how would it be handled if there are multiple providers in a region and one provider becomes preferred and begins to see an imbalanced number of clients? Would there be a mechanism for petitioning for corresponding payment adjustment? So let's play this out. Question: subcapitation paid multiple, and so let me just grab a spreadsheet real quickly, and I'll give you an example of what the person is talking about. So what I have is provider 1, provider 2. I'm going to do 4 providers. 3, provider 4. And let's say that there's Medicaid lives. Let's say that there's a total of 100,000. Oops. That's to 0. And just for purposes of my explanation, let's just say that 25, that it got divvied up evenly. So that this is easy because we know that it's 25% for each provider organization. And let's say that the patients that start coming into, okay, so let's just say that so what's going to happen is if whatever the amount of money is going to be divvied 25% to each provider organization. That's going to be their monthly check, and they're expected to serve everybody that comes into their organization. So let's just say that there's 1,000 patients, and 300 of them go there, and 150 go there. And 200 go there, and 350 go there. So what's going to happen? So this is the question that the person was asking. What do you do? What do you do if the way that people are choosing to walk with their feet looks really different than how the capitation payment was figured out? Well, so the whole thing just basically goes south, and because the provider 1 that should only be serving 250 clients is not getting enough, provider 2 that's supposed to be serving 250 clients is getting too much money, provider 3 is getting too much money, and provider 4 is getting way too little money. And so the only way you would do it, what you'd have to do is you'd have to do this math well, let's see, you could do a math problem where you'd say we're going to count the number of clients each month and adjust. But what happens if the clients are at different levels of severity? There's like, what happens if the number of services that are being provided doesn't correspond to the ratio of number of people that are being seen? What I said earlier is that if you're going to consider subcapitation, you can really only do it if there's one or two providers in the geographic region. Otherwise, this is like a really wonderful example of how the whole thing blows up. And some organizations get paid too much and other organizations don't get paid enough. And it destabilizes the system. So I really appreciate, that's like the best way to dig into that question that I didn't feel like I didn't do a good job before you asked it. Thank you. I'm going to shift gears now, and I'm going to go on to the next chapter, the final chapter. And please keep firing questions in about anything I'm talking about. And I'm still going to get back to the question about benchmarking and evaluating outcomes. So in the toolkit, there's an infographic called 7 Steps to Developing a Pay-for-Performance Program. And I want to say a few words about those steps. So what we have is this idea of identify what's important. And what I mean by that is identify the performance measures that are important for the population you're serving. Pay careful attention to the national performance measurement work that's continuing to grow. And so look at the whole universe of measures that are being considered. And then I think it's really, really, really important to select the vital few. So the Healthcare Authority has been doing this. There's a work group going on now about more behavioral performance measures. Crosswalk the performance measures to service, and then crosswalk the measures to the service areas that should be accountable for each measure. And then select the vital few for each service area that are high-value candidates for the P4P program. So let's take a couple look at measures. See, one of the things I did a project for the National Council where I looked at all the federal measures in 25 different reporting systems that the feds have that are relevant for people with behavioral health disorders, and we found 250 measures. And so I'm not going to go there because that's like way too many. But if we take the P4P, that's the acronym for Pay for Performance, that are in the 4 payment models in those 4 slides, what I have is for capacity payment, we believe that response time, access time is really important. Client and family satisfaction or experience is really important. Referring party satisfaction, because there's a lot of cases where people being referred into capacity payments are coming from another organization, individual, provider. Did the problem get resolved? Because a lot of these capacity payment services are front-end funded. And did the person who was served get successfully transitioned to their next step on the journey towards whatever they need to be healthy and whole? So this is an example of, this is what I pulled out of that first slide that we were looking at. Let's take a look at the fee-for-service model. Response time and access is still important, as is client and family satisfaction. So these are generally for ongoing services. But we get down into outcomes. Is the service achieving the behavioral health outcomes that are important to the client and the system as a whole? And are they achieving health outcomes? And is the care being provided within utilization management guidelines? That's shorthand for, are we providing too much care or too little care, is an important measure for many fee-for-service paid programs. You notice that for case rates, this is for ongoing episodes of care, exactly the same as fee-for-service. Access, satisfaction, outcomes, and is the care being, in this case, is too little care being provided. We're paying a bundled payment. Are you providing enough care, or are you spreading the butter on the toast too thin, which may potentially result in poor outcomes? And then subcap, it's the same issue. The same suggested measures or sample measures. So for ongoing care, these 5 are really important measures for sort of front door crisis, fire department type services. The blue measures are generally recommended. Let's see, I'm going to just say something. I don't know if we're all going to turn into a pumpkin in a half minute, because the timer, the webinar was set for 60 minutes, and we're just, I started up 59 3/4 minutes ago. So if we turn into a pumpkin, I'm really sorry, and what we'll have to do is, there's just a few more slides, but we'll have to figure out a way to get you the rest of the material. We'll know, looks like we're okay. We have 10 more minutes. So I talked about the examples from the toolkit. The Certified Community Behavioral Health Clinics, which is the new program that's rolling out from the feds you probably all know about, they have a set of quality bonus measures for states that are moving into the CCBHC program, unlike Washington, for programs that the feds are offering a per visit based payment and a monthly case rate. They're basically saying if you're going to be a CCBHC, your state will either pick it's a per day, but basically a per visit, per encounter payment, or a case rate. And there's a quality bonus program that's optional for the per encounter payment and required for the case rate. And these are the 6 required measures if you do CCBHC case rate: follow-up after hospitalizations for adults and kids, adherence to antipsychotics for individuals with schizophrenia, initiation and engagement of alcohol and drug treatment, suicide risk assessment for folks with adults and youth with major depressive disorder. And then there's some optional measures, and then you can add your own measures. So there is a process that's happening around the country of identifying the vital few. So once you've identified your measures, it's really important to figure out whether you have the data collection and infrastructure in place to implement the pay-for-performance model, assessing the existing capabilities and estimating what time and costs will be necessary to fill the gaps in this collection process. I cannot tell you how many times pay-for-performance models have been put into place where they didn't do this step 3, and the whole thing just totally failed. So it's important to think about that and then revise or design your list of measures that you can really pull off. And then there's a 4-phase process that many organizations are considering a best practice for rolling out pay for performance. And I want to just take a minute and talk about that. So what we're doing in a project in Portland around outcomes-based care is we're starting with phase 1 called pay for participation. We agree to participate in developing a quality contract that describes the P4P design and measures, and we work on it. So we being the providers, and the providers get paid for that. Additional payments are made in the second phase to support the cost of moving to P for P, including implementation and use of health information technology. So in some systems, they combine phases 1 and 2 and just make it a single phase. But it's being very thoughtful about making sure that this is a long-term quality improvement project, and we need we need the providers involved. We need you to get providers to get your reporting system in place, and it doesn't come free. So we're going to pay you a bonus payment for doing that. In the third phase, we're going to pay you for hitting process targets, X percentage of patients at breast exams or colorectal exams. And then the fourth phase, we're going to pay you for outcomes, which is different than process, whether the care is working. How many people have an A1C level under 7? We'll pay you a share for actual reduction in emergency room costs. Again, sometimes phases 3 and 4 are combined, so every situation is different, but it's important to think about all 4 of these phases when doing a pay-for-performance design. Now, if somebody asks a question, will there be a reporting mechanism in place to ensure that a client falling out of care isn't misinterpreted as a positive thing and or incentivized? So that's a great question. I'm going to come back to that. For example, a reduction in emergency room visits for a client, but no other appointment with a PCP. Or mental health CD to replace prior heavy utilization. Yeah, so I'm going to talk about some of those questions in just a sec. But before I do that, I want to say a couple things. These performance measures are generally measured at a system-wide level. So what you need to do is you combine up all the results from the performance measures, and you identify, and before you get started, you need to identify this thing called baseline for each measure, which is defined as where you are now, and the benchmark, what your goal is. So let me just repeat myself. Baseline is your current performance level. Benchmark is the desired performance level. Let's look at an example. In Oregon, they have the CCOs have 17 performance measures that they pay incentives on, and this one should look familiar. Follow-up within 7 days after discharge from a hospital for mental illness. And the question is, what percentage of the patients in each of the 16 CCOs in the baseline year of 2011 got in to see a provider within 7 days? And we can see that it ranges from 57% to 89%. So in this case, it would be every provider. The providers would be the bars, and what we'd be doing is measuring where everybody was at. And then what the state did, the Oregon Health Authority did, was they went to the federal Medicaid data set, and they said, what was the 90th percentile nationally of follow-up? So in 9 out of 10, for the people that were in the top 10% of performance, what were their numbers? It was 68%. So what they did was they said, we're going to set we have our baseline because we measured. We're going to set our benchmark at 68%. And then what they did was, and this is really, really, really important, was you get your bonus if you do better, if you improve on your baseline, or if you hit the benchmark. You get the bonus if you improve on your baseline or if you hit the benchmark. If you hit the benchmark, you don't need to, you're good. Like if you're at 89 and you drop down to 88 or 87, you still get your bonus because you're above the benchmark. And so these measures are being done for the whole system of care. Looking at each provider, it's a system-wide measure. And so once you figure out what your measures are, what your benchmark and your baseline is. Then you need to determine the size of the funding pool. You need to decide how frequently you're going to pay and what method you use for improvement, which I just gave you a strong opinion about. And then you implement carefully monitoring the data flow, and then you move into and then you decide what phases that you're going to work with, and you keep moving up the phases until you basically get well into your continuous quality improvement program. The last thing I want to say about this before I jump into some of the other questions is there are some performance measures where a system gets so great at it that everybody is like scoring really high, and then you just say, okay, it's time to retire this performance measure and say, what comes next? What do we need to be working on next? So the performance measurement pay for performance process is a quality improvement process where we're just supporting each other with funding to help the system improve. Now, so if a client is falling out of care, one of the things that we haven't figured out how to capture the data on is graduation versus dropouts. So if a client is dropping out of care, that's generally not a good thing. If a client is graduating from care, that's generally a good thing. And that's an example of a performance measure where we don't want, it's a really beautiful example of we don't want to put in place a performance measure related to those two things until we have a way to really cost-effectively determine which is which so that we're not paying for something that we actually don't want to be paying for. So if that makes any sense. Somebody said, this seems similar to the meaningful use payment model. Is there a reason for similarity? Well, there are 26 pay-for-performance programs in the federal government. Meaningful use is one of them. And so it absolutely is similar because what's happening is that what we're trying to do is create a system where it looks similar across all the different payment systems so that providers are having as few targets to go after as they work on pay for performance. And so yes, indeed, and we did our analysis and we pulled the 250 measures. A meaningful use was actually one of those measures. We're pretty much out of time. So what I'd encourage you to do is if you have other questions, I want to honor people's schedule. Please write me at Dale at djconsult.net. And I'll be more than happy to follow up with you